afternoon, everybody. We're here with Dr. David Tourgeman. Dr. T, if you can give us a few minutes on what is a uterine fibroid, how common do you think it is, how does it affect implantation pregnancy?
So the best way to think of fibroids in general is that they're growths. They're growths of the muscle of the uterus. And there's three big kinds of fibroids that we know about. They're sort of given that type, if you would, based on their location. There are some that are subserosal or growing outside of the uterus. There are some that grow within the muscle of the uterus. And then there's some that grow within the cavity of the uterus. So those sequentially are called subserosal, intramural within the muscle, and then submucosal, those fibroids that grow within the cavity of the uterus, which is critically important to our field in that these fibroids can impair the ability of an embryo to implant.
How do you feel that the cause of action of failure of implantation happens because of a fibroid that's either impinging in the cavity or in the cavity? What is the mechanism?
Really, we think that the bulk of it is almost like an irritation that occurs within the cavity because it's a foreign object inside the uterus, much like an intrauterine device or an IUD, which is a contraceptive device. It causes white blood cells to migrate to the area. And what do white blood cells do? They attack foreign things. And a foreign thing, of course, is either sperm or embryos. So we think that that's probably part of the mechanism of action.
So it's some kind of an inflammatory response that prevents an embryo from properly invading the endometrium and becoming alive subsequent to that.
Yeah. I mean, there's so many things that happen at the level of the uterus during the early portion of pregnancy. And literally what happens is that the embryo needs to grow into maternal blood.
How about early first trimester loss? What do you feel is the mechanism of action where a fibroid is in some kind of a location where the embryo is implanted, but then it has some difficulty in fetal growth and then there's a subsequent loss?
The speculation is that if there's indeed a fibroid that's growing within the cavity, that it may implant. And either there's a disruption in its ability to grow because of the impingement of the fibroid on the pregnancy, or furthermore, there can be, if it implants around the fibroid, there can be a lack of blood supply that feeds the embryo, and therefore, with a lack of nourishment, that can result in a miscarriage.
So the placenta literally just disconnects from the underlying endometrium because of the mechanical or inflammatory issues from that tumor?
Yes, and or it stifles the blood supply to continue nourishing it.
So it's multifactorial. How do you diagnose these? What imaging procedures do you use? What diagnostic procedures do you use to make this diagnosis and then subsequently counsel your patient on essentially leaving them alone or getting involved with some kind of a surgical removal?
Just really talking about the submucosal myomas, or the ones inside the cavity, there's really three big techniques that we use to identify if they're impairing the inside of the cavity. And the first and most classic one is doing something called a hysterosalpingogram, which is a radiograph, an X-ray, where they put dye into the uterus and then the dye comes out the fallopian tubes. But in essence, it gives you information not only about the fallopian tubes, but also about the shape of the cavity and whether there's some type of mass growing within the cavity.
A filling defect.
A filling defect.
Right.
That's
so
exactly
where
right.
we normally see the dye, we see an area that doesn't fill up with dye. And that would lead the clinician to believe there's something there.
That's correct.
And that maybe the next step should be taken.
Yeah. The second option, and a little bit more tolerable often to the patient, is an ultrasound with water that we put into the uterus. And the reason that it's a little bit more tolerable is because the dye that we use for the hysterosalpingogram is quite thick. It can cause cramping, whereas saline is a lot less viscous and therefore more easily tolerated by the patient. But the idea here is not to do a radiograph, but do an ultrasound, which is also a little bit less intimidating for the patient.
Okay. How about MRI or hysteroscopy? When do you use those?
Hysteroscopy can certainly be used initially. However, hysteroscopy is the operative way of diagnosing or treating a fibroid. Usually what I'll do is I'll try to identify whether there's a problem with either the hysterosalpingogram or the saline ultrasound. And if there is a problem, then what we will do is go ahead and perform the hysteroscopy and treat the fibroid as well.
I get patients always asking me, oh, my gynecologist said I can get pregnant with this fibroid. Or you want to tell our patients what Depo-Lupron is? How does it work?
Depo-Lupron or Lupron is basically a way of shutting off the patient's brain from producing hormones. So there's less stimulation to grow these fibroids, and they in turn shrink down as a result of that.
How about size of fibroids?
Almost all of us would say that if the fibroid is inside the cavity, it needs to be removed. The question then becomes, what about the fibroids that are not so obvious? For example, the ones that are growing within the muscle of the uterus. There's been a lot of discussion about when is the best time to remove these fibroids if they're growing into the muscle. I think that most of us feel that if there's any distortion of the cavity, we would tend to err more on the removal. The study that we discussed basically recommended that if these fibroids get bigger than 4 centimeters or roughly 2 inches in size, that you would consider removing them. I think that part of it also depends on if there's symptoms, right? So if the patient is having excessive bleeding or pain from these fibroids, that's a good time to consider removing it before conception occurs. If they have a history, certainly, of having had a miscarriage that was precipitated because of rapid growth of the fibroid, that would certainly be a reason to want to remove it.
How many surgeries can a patient have on her uterus?
I think that most obstetricians sort of shy away from doing more than 3 C-sections.
How about myomectomies?
Myomectomies, that's the removal of the fibroids where one has to cut into the muscle of the uterus, is potentially a lot more deleterious on the integrity of the muscle. In fact, most OBGYNs will recommend 3 to 6 months for healing of the muscle of the uterus before trying again. I certainly don't think that going beyond 2 or 3 times is recommendable, and so you try to take care of the issue the first time around.
Is there a role for surrogacy for some of your patients?
I think the most obvious one is if the patient has medical problems that disallow her from attempting the first myomectomy. The other one is if they have had myomectomy and they're recurrent and they're not quite symptomatic, but they're potentially problematic for continuing on a pregnancy, or if the patient is just really emotionally done and does not want to have another operation that can be quite significant.
This is Dr. David Tourgeman. Please come see him in West Los Angeles. David, thanks very much for making the time.
Thank you so much for having me.